Hello, everybody. Welcome back to the Incubator Podcast. We're back today for an episode of Journal Club. Daphna, good morning. How are you?
It's not morning.
It's definitely not morning.
You've thrown me off already, and we're just starting. You don't have to lie to the people. We don't have to record in the morning.
No, but it's going to be released in the morning. I remember
It
when I
is
was a
released
kid
in the morning.
and I
Okay.
was watching these shows and you knew that it was recorded in the afternoons and they were saying good morning. And I'm like, that's so silly. And look at me doing that today.
You had a long day at work, but here
Yeah.
we are recording after hours around dinner time. My dinner time, not the French dinner time, but my dinner.
Yeah, no, dinner time for me is not until for 3-4 hours still. So that's good.
All right. Well, tell us what's new.
Lots of things are new. I'm going to mention the first thing, obviously, is that as we are recording this on Wednesday, October 22nd, the updates to the NRP has been released. NRP 9th edition. You should have anybody should have received an email with a little sheet where basically you have some of the differences between the NRP 8 and NRP 9. That said, we're going to have a special episode next week where we talk to Henry Lee, who is one of the member of the steering committee, and we're going to go over all the updates that you should be familiar with when it comes to NRP 9th edition. So don't fret if you are now like me saying, oh my God,
Searching your email.
I'm I have a busy week, and on top of that, I have to see what I have to do different in the delivery room. We've got you covered, and we will do that next week with Daphna and with Dr. Lee from California. So very excited about that. In terms of other announcements, we are very excited about the preparation work for Delphi, the Delphi Neonatal Innovation Conference. That is promises to be truly an exceptional edition this year. I'm so excited, and it's not the feeling that is usual. Usually, when you prepare something and you spend a lot of time, you beat it to death, kind of, and
Just ready for it to get there.
yeah, you kind of oh my God, I just can't wait for it to be over. But now I'm genuinely excited about this edition. We have a very exciting program. We have a very exciting list of speakers. We're going to talk about so many different topics. We're going to talk about advocacy. We're going to talk about neonatal neurology. We're going to talk about neonatal pulmonary medicine. We're going to talk about career. We're going to talk about stem cells. There's going to be so many interesting topics that I can't wait. I can't wait to be there and to hear these guys talk. And there's going to be so many other activities, whether it is the trivia night, whether it is the TEDx event, or these special panels that we have scheduled on AI, on twins. It's just going to be a lot of fun, and it's going to be relaxing. That's what I can promise. That's the thing that's really where I feel like our expertise shines, because
Can you say we have? Is that an expertise?
I was thinking about that, right? I was like, what makes us sort of good at doing this? Because we're not the ones speaking.
No.
People don't come to hear us speak. The speakers are really the ones that are exceptional with the work that they've done. It feels like we're not the greatest conference organizers, because we'd probably take twice as long to do something than anybody else.
You're pulling back the curtain here. You're pulling it back. Everybody can see how conference planning is going.
But truly, you have
we got some extra help this year. We're figuring
we have
it
some
out.
extra help this year, but we have no business doing logistics for a conference. I'm just letting you know.
Yeah.
We're good at finding speakers. That's kind of what we do with the podcast and everything else. But to pick the number of tables that need to this is definitely not
It's exhausting.
It's exhausting. So I'm but the conference really is awesome. And so I was thinking about it, and then I was thinking about that. I'm we have an ability to make it more complicated for us, which is a lot more work. But what that leads to is a combination of intellectually stimulating conversations and lectures, all the while having a very relaxing and peaceful environment, so that you leave the conference sort of energized and you're I want to go back to work tomorrow and start doing some of that stuff in my unit tomorrow. So yeah,
we want people to be comfortable, right? I think that's what we posted about this a few times. It feels like we're inviting you to our homes. We want you to be comfortable. We want you to chat and have a good time, and have your brain think about new ideas and talk to new people.
In the conference hall, you're intellectually going to be very stimulated, and when you're going to depart the conference hall, it's kind of like a resorty type of feel where you're oh my God, there's water, it's sunny, I'm comfortable. That really to me plays a huge role in how people leave the conference. And again, I can't, without boasting too much, there's a lot of work product that is currently being done from people who met at the conference that
Mhm.
reach out to us and be like, hey, me and this person, we met at Delphi and we've been sort of sharing ideas and we're
Yeah.
working on this project. Um, that's to me is
Yeah,
very cool.
I feel like a lot of people who come to Delphi kind of self-select. They are interested in coming to we're like a medium-sized conference, right? We did that by design. We want people really to interact and engage. So don't be afraid about coming by yourself, right? I think people started coming back together as a group. They met at the first Delphi, they came back as the second Delphi, coming back for the third Delphi. That's really cool. I
Yeah.
think really cool.
And like we've always said for Delphi, if for some reason the price tag of the ticket is an issue for you and you say this is too expensive, which is not, by the way, it's not. Like
Mhm.
there are many other conferences that are way more expensive than ours. Most conferences are more expensive than
Mhm.
ours. That being said, if this by any chance is the obstacle that prevents you
Right.
from attending, send us an email. Like you don't need to apply for a grant. Like we will work with you. Like we've done for everything that we do.
Mhm.
Yeah. So just FYI, if this is something that you say, oh, we'd love to go, just don't have that kind of money on hand right now, just let us know. We can't pay for your trip. We can't pay for your hotel. That is unfortunately beyond our control. But if your registration is the issue, it won't be. So anyway,
And but on that note, the hotel is really, really freaking cool, and they have offered us such a good price. You cannot come to, I think, anywhere in Florida at this price
no.
point and take a
What is
look at
it?
the
Five
Flow
hundred bucks.
Hotel.
500 bucks for 3 nights
Yeah, total,
in
total.
Fort
In
Lauderdale,
Fort Lauderdale,
by the water, beautiful rooms.
you can walk to the beach.
I
Um,
usually don't stay but for the people who don't
we're
know,
s
when we do Delphi, I actually drive back home every night because it's reasonably close. I'm staying at the hotel this year.
Well, and I wanted to say definitely people should take a look. They have like 2 bedrooms, 3 bedrooms. You can come with colleagues and split the cost. And we really try to make it accessible for
Yeah.
people. So,
So great conference. We've had a lot of registrations thus far,
mhm.
and very excited about that. Go check it out. You can find information at delphiconference.org, or you can find more information on the Incubator website, the-incubator.org/Delphi. Both links will lead you to the same place.
Sneaky.
Yeah, we don't. What do you think? We're making multiple websites over here? Like, all right. That being said, we should get started with Journal Club. What do you say,
Mhm.
Daphna?
Let's.
Let's. Is that what you
Mhm.
said?
Mhm.
Let's. All right. The first paper that I want to go over is a paper that came out in the Journal of Pediatrics. It is called Infant Renal Replacement Therapy Using CARPEDIEM, a multi-center observational cohort study from the Iconic Learning Network.
You've been
Uh,
teasing this paper to our team.
yeah, it's so interesting. Um, and yeah, so his first author is Kara Slagle, I believe, and this is coming from the team at Cincinnati. I believe that the team at Cincinnati has been one of the most active ones on when it comes to using Carpe Diem for continuous for infant renal replacement therapy. So we've had some Delphi talks actually. We have some talks about nephrology. Dr. Katsufis, who gave a beautiful lecture on basically infant renal disease and proper follow up and so on and so forth, is really something I recommend you guys watch. It's on our YouTube channel. But this paper really looked at the use of Carpe Diem as continuous renal replacement therapy. So I'm going to first talk a little bit about what is continual renal replacement therapy. It's increasingly being used in infants, even though peritoneal dialysis remains the most common modality of renal replacement therapy in this age group. Um, so I want to make sure that like people understand. So obviously, many people may have experience with the peritoneal dialysis. You put a peritoneal catheter, and then babies are subsequently ready for dialysis. The innovation with this Carpe Diem machine is that you can do this without a peritoneal catheter, and you just need like a venous access. So either internal jugular or femoral venous access. It's a double lumen. So basically you draw from the vein and you replace through the vein, and it allows us to Us. I've never used the machine. Sorry, I've just been watching a lot of videos about it.
It
Um,
allows some people,
it
some
allows the ones
experts.
who use it to really perform dialysis for very, very small babies, all the way down to 2 kilos. There's even some. I mean, we'll talk about it. There's some reports of people using it in babies who are smaller, and so it's very neat, because you're not dependent on any catheter placement. Like, with a little bit of some POCUS and a PIC team or something, you could get enough access to actually run dialysis. Now, so the background section is obviously very interesting. It mentions obviously that CRRT through CARPEDIEM is used as a bridge to peritoneal dialysis or following peritoneal dialysis failure in infants with end-stage kidney disease. There's a survey of 39 North American pediatric renal programs showing that more than half report using CRRT, I'm sorry, I've been saying it wrong all this time, as a bridge to peritoneal dialysis, occasionally and successfully. It's been supported by prior reports showing that it is successful for use in preterm neonates who had failed peritoneal dialysis, and that CRRT before peritoneal drain placement may even promote optimal healing of the catheter, because you're really already making progress while the patient is healing after the placement of these tedious peritoneal dialysis catheter. For infants, this therapy provides critical clearance, right, of nutrition and nutritional support while maintaining fluid balance. Um, and it remains physiologically and technically challenging, right, to do that. So the main challenges come from using filters with large extracorporeal volumes relative to patient size and the need for large bore catheter, right? These are the two main obstacles to this particular therapy, even though it's an improvement on what we have now. Um, Before 2020, pediatric specialists had to adapt basically adult dialysis devices like the Aquedex system to provide modified hemofiltration for small infants. And since the US Federal and Drug Administration approved the CARPEDIEM, which stands for Cardio-Renal Pediatric Dialysis Emergency Machine, that was designed and created out of Italy, I believe, um, it's been revolutionary. It can be used officially for babies between 2.5 and 10 kilograms. Like I said, some people use it for even lower. And so, to support the learning and the collaboration around this new technology, they created this thing called the Iconic Learning Network, which stands for Improving CRRT Outcomes in Neonates and Infants Through Interdisciplinary Collaboration. And the objective of the present study is to evaluate indications and short-term outcomes for infants who were treated with the CARPEDIEM across US centers. So this is a multi-center prospective observational learning health network and registry focused on infants receiving renal replacement therapy with this machine between September 2020 and June 2024. It includes 4 sites covering patients who completed a treatment course. So a treatment course was defined as a series of procedures separated by no more than 72 hours, and the indication for treatment were determined by the treating team. So the indication to even begin dialysis were not really monitored by the trial specifically. And you could have more than one indication actually to enter. Um, the researchers also recorded whether other renal replacement devices were used before or after the carpe diem was actually resorted to. Before each course, the team calculated the percent fluid balance for using both weight-based and intake/output-based methods. Clinical sepsis was defined according to the Sears Systemic Inflammatory Response Syndrome criteria. They collected data on vasopressors for blood pressure up to 4 hours before the initiation of CRRT, and tracked intervention for hypotension during therapy. They tracked also fluid boluses, vasopressor escalation, hydrocortisone administration, and so on. They divided their cohort into 2 groups: the ESKD cohort, which is the end-stage kidney disease cohort, which included infants with congenital kidney failure or severe congenital anomalies of the kidney and the urinary tract system, who were anticipated to need long-term dialysis shortly after birth, and who were initially placed on the Carpe Diem machine, or they had already failed peritoneal dialysis. Then they had the non-ESKD cohort, the non-end-stage kidney disease cohort, which included infants who received the dialysis via Carpe Diem for something more acute, like an acute condition, including acute kidney injury or really positive fluid balance or severe electrolyte disturbance. Um, they had two primary outcomes. One of them was survival to treatment course end and survival to hospital discharge. So I think that we've gone over enough. There's not a lot of use yet of this particular device, so the population was quite small. So in the end, I'm just going to pull up my notes. The results section shows that the demographic and clinical characteristics from 67 patients were reported. Right, the cohort was predominantly male, with a median gestational age at birth of 36 weeks. The patients were predominantly, like in 80% of the cases, admitted to the NICU on day of life 1, with an admission weight of about 3.01 kilos. So again, we're not really talking about it's not a paper where they're pushing the envelope and really trying to try dialysis on very small babies. For those that were not admitted immediately following birth, the primary indication for admission was severe respiratory failure or kidney failure. CACUT, the congenital acute kidney, what is it again? Um, you're going to have to remind me of.
Congenital anomalies of kidney and
And the
urinary
urinary
tract.
tract, thank you, was present in 54% of patients, with 13 having a lower urinary tract obstruction and 10 with bilateral or unilateral solitary kidney with multidysplastic kidney disease. So the initial treatment course indications, which could be multiple, were end-stage kidney disease as a bridge to peritoneal dialysis in 54% of cases, positive fluid balance in 46% of cases, and 43% had acute kidney injury, 21% electrolyte abnormality. No patient treated in the context of inborn error of metabolism. The median age at the first treatment course was 28 days, with a corrected gestational age of 39 weeks. So in terms of treatment courses and outcomes, so they basically are going to give you the results in 3 parts. They're going to give you the overall results without separating the patients between the end-stage kidney disease and the non-end-stage kidney disease, and they'll tell you for each one. So the 67 patients, let me just see. The 67 patient underwent a total of 93 treatment courses. 14 patients received more than one course. The median dry weight was about 3.4, and 13 patients were actually below 2.5 kilograms. That represented about 20% of the cohort. They go through a lot of information about how many filters they used, where the procedures were located, how long the filters lasted, etc., etc. But the treatment course outcome data was available for 64 patients. 84% of the patients survive their treatment using the CARPEDIEM machine. 63% of the patients survive to a different device, I'm assuming a peritoneal dialysis. Major complications were reported in 26 or 41% of patients, with 2 having complications in more than one treatment course. Sepsis and bacteremia and new or worsening intraventricular hemorrhage were the most frequent. In the subject with complications that included any bleeding, 2 subjects had no exposure to heparin therapy, and 5 were on systemic anticoagulation before renal replacement therapy. 63% survived to hospital discharge. I think this is a very impressive number. There was no difference in survival by weight at the first treatment course. And of the 23 patients who did not survive, 18 were transitioned to comfort care. The cause of death were most likely pulmonary hypoplasia and or sepsis. So it's for babies who have such severe presentation that they need to go on dialysis to generate 63% positive outcomes is very, very impressive. I think we should. I was very excited about that. When they looked at the treatment outcomes based on the groups, so let's look at the ones in end-stage kidney disease. These were the ones who were probably the more severe ones that we knew were going to have kidney failure right at birth. They had 36 patients. The median dry weight was about 2.6 kilos, and they were about 18 days of life. They talk about which catheters that they used, and so on and so forth. But in terms of treatment outcomes, survival to hospital discharge for that group was 67%. Of the 11 who did not survive, 9 transitioned to comfort care. Again, pulmonary hypoplasia being the most common cause. 21 of the surviving patients transitioned to another form of renal replacement therapy, commonly pulmonary peritoneal dialysis. Continuous or prolonged intermittent RRT using another device was the case in 9 other patients, and intermittent hemodialysis in 2. Finally, we talk about the non-ESKD patients, the one who had more of an acute condition, kind of like the AKI. We're talking about babies who represented 31. It was 31 babies, and again, similar findings in terms of the setups. In terms of the hospital outcomes, they were reported in 30 of the 31, and survival to discharge was 60%. The most common cause of death, sepsis and infection. 9 of the non-surviving patients underwent redirection to comfort of care. So I think this is very, very interesting. The conclusion of the authors are that this US cohort study shows that CRRT survival in infants treated with CARPEDIEM exceeds 60%, and more than half of the treatment indication were for end-stage kidney disease as a bridge to dialysis. So I wouldn't be surprised if this become more and
Uh-huh.
more of a tool in the arsenal of the neonatologist. I feel like since I was training, it seems like dialysis was something that they did in the PICU, but not in the NICU. But it looks like it's coming. And it looks like for these babies, especially we see very frequently, not very frequently, but we see commonly babies with severe positive fluid balance. And maybe if your hospital has purchased some of these devices, we might consider putting these babies on dialysis. So it's very interesting.
Yeah, exciting to have, more things to offer for sure.
Yeah, especially, without making this too much of a stereotype, but the babies who have severe neck, for example, right, and who
Mhm,
then go on to have surgery and they're very edematous and they go
mhm,
into some AKI, right, and you're trying to like titrate their electrolytes, but they're and you can't do much, and you titrate, and it takes days for their whatever potassium, sodium to get back to normal. Maybe dialysis is the option to actually get a much swifter correction and less risk of complications because
mhm.
it's these are the patients that we stress out the most about, and yeah, the PICU has dialysis. We don't.
Yeah. Well, to be fair, there are some NICUs who are doing dialysis, but it's very few. So,
It's
yeah,
interesting,
this
but
is a totally different
yeah,
system, you know?
and the peritoneal dialysis sucks. I'm sorry, like these
Yeah.
peritoneal catheters, I've never had a good experience,
Well, you can't use them right away, there's
and they
so
get
many.
infected, and
Right.
they don't function. It's
Mhm.
it's uh, it's not always super straightforward.
Mm-mm.
And by the time you're ready to actually start dialysis, like Lord knows where you are at that point.
Right.
Because
That's right.
yeah,
All right, buddy. Well, I have a different type of conversation.
let's do it.
This one's in Journal of Perinatology. This is short-term and long-term effects of vitamin D supplementation for preterm infants. This is actually a review and meta-analysis. Lead author Sung Hyun Shin. I
Yeah,
think I
your
said it
Korean
right.
is getting better,
I think I said it right. I hope so.
right? They're from Korea, if I remember correctly.
Yes, yes.
Yeah,
This is
so your
coming from
Korean is getting
Korea.
good.
Thank you. I don't know any Korean. I will work on it. But the goal was to study short-term and long-term effectiveness and safety of high dose. So they were using greater than or equal to 800 IUs per day compared to low dose, which was less than 800 IU per day. So this was a meta-analysis. So some studies used different ranges, but for the low dose, they were all less than 800. And then try to decide, is there an optimal dose strategy for vitamin D supplementation? So they looked at preterm infants with a gestational age less than 37 weeks. Their intervention, like I said, was a high dose vitamin D3 greater than or equal to 800 IUs per day. And this was started during the NICU stay, obviously, sometime after birth. I already told you about the comparison, and they really wanted to look at a whole bunch of outcomes. So in the short term, they wanted to look at the serum, 25 OH levels. They wanted to look at vitamin D deficiency levels, so less than 20 nanograms per milliliter. They wanted to look at VD or vitamin D excess, like was there a problem if we gave too much? Skeletal bone mineralization, clinical outcomes such as growth, RDS, BPD, late onset sepsis, length of hospital stay, mortality. And then some of the biochemical markers, parathyroid hormone, calcium, phos, alk phos, osteocalcin, and urine calcium to creatinine ratios. Then they looked at long-term outcomes. They looked at, again, the serum 25-OH level, bone mineral density, mortality, and neurodevelopment. Okay, so what did they look at? After all of their evaluation, they included 21 studies from 9 countries. They came from Canada, Egypt, Finland, India, Iran, Israel, Turkey, UK, and the US. In total, they had 1,130 infants that met the final inclusion criteria, comparing those studies. All right, let's get into it. The short-term outcomes. So the serum levels, not surprisingly, were significantly increased in the high-dose group compared to the low-dose group. This makes sense. And the risk of vitamin D deficiency was significantly lower in the high-dose group. Um, Interestingly, though, there was no significant difference found in the risk of vitamin D excess. So that's good news. Skeletal hypomineralization showed that the high dose group had a significantly lower risk of skeletal hypomineralization compared to the low dose group. They looked at some of those other growth parameters: weight gain velocity, length gain velocity, and head circumference gain velocity. All demonstrated a significant increase in the high dose group compared to the low dose group. Those clinical outcomes, RDS, BPD, late onset sepsis, and length of hospital stay, there was no difference between groups, but the risk of mortality was significantly lower in the high dose group. The PTH level was significantly lower in the high dose group. This makes sense, and the levels of other biochemical markers did not differ. And then they took they took the high dose group and they divided it into 3 additional groups. So there was an 800 IU group, a 960 to 1,000 IU group, and a 2,000 IU group. We haven't used 2,000 in our unit, so I thought that was interesting. All 3 high dose groups demonstrated a significant elevation in serum 25-OH levels compared to the low dose group. So even as individual groups, even the 800 group showed an increase level. The risk of vitamin D deficiency significantly decreased in both the 800 IU and the 1,000 IU groups compared to the low dose group. However, the risk of vitamin D excess showed a significant increase, but exclusively in the 1,000 IU subgroups and not in the 800 IU group. Obviously, the numbers in each of those groups became very small, and there were less trials, obviously, that evaluated them. They wanted to look at the long-term outcomes, and they actually did not find a significant difference in serum 25-OH levels between the high dose and the low dose group in the long term. They wanted to look at there was a single study that looked up they were following up vitamin D deficiency and vitamin D excess, and vitamin D deficiency showed a significant decrease in the high dose group. So the babies who got high dose, even long term, had less vitamin D deficiency. So that group of less than 25, of vitamin D less than 25. And there was no significant difference long term in vitamin D excess. In a few of the studies, bone mineral density was looked at corrected age 3 months. There was no significant difference in groups. And there was one study that looked at bone mineral density at 9 to 11 years. No significant difference between the two groups. In the one study reporting on mortality and neurodevelopmental outcomes at 2 years of age, significant differences were not found in terms of mortality, cognitive and language impairment, and any marker of total neurodevelopmental impairment. So basically, this was looking at kind of the short-term in NICU parameters and then trying to assess about if increased supplementation had any significant impact on long-term outcomes. But I was kind of impressed by the short-term outcomes, especially as they related to growth, And in general, when we start, I mean, we monitor vitamin D levels pretty
Yeah, very
closely in our
closely.
unit. So we make adjustments individually for each baby. Notably, we've had to increase vitamin D a lot. Perhaps we should start at 800 or at least 600. We typically start at 400 in our unit.
Mhm. Yeah, I mean, vitamin D is that agent that keeps coming back in the ICU as
Well,
having.
and all over in preventative medicine and
I
stuff like
know.
that, it's really, I don't know, hot
Yeah,
topic.
it has a lot of good properties, and yeah, it's interesting. I mean, it feels like a lot of our babies do end up going, like you said, to
Mhm.
800, and so yeah, sometimes I'm resistant to to
Start
change,
high.
but in this case, maybe.
All right, your turn.
My turn. All right, I'm going very innovative for this particular journal club. I kept
Okay.
the next article I wanted to review. Um, let me pull it up.
Did
Yeah,
you forget that you were next?
no, I did not. It was published in the European Journal of Pediatrics, and it's called "Nebulized Nitroglycerin as an Adjuvant Drug in Management of Persistent Pulmonary Hypertension of Newborn,
Oh,
a randomized controlled
that is
trial."
interesting.
Yeah. Marwa Mohammed Farag is the first author. This is coming out of a group from Egypt. Hello to all our listeners in the country of Egypt. So the introduction is fairly a good review of what persistent pulmonary hypertension or PPHN is, mentioning that it is indeed a serious and life-threatening condition, and mentioning that it has to do with
That
the
much we knew.
that much we knew, right? That we failure of the pulmonary vasculature to adapt to birth and failure of the PVR to decrease. Now, this mentioned how the diagnosis is primarily clinical, but that echo remains essential for confirming, and that the goal in the treatment of PPHN centers around optimizing oxygenation, promoting pulmonary vasodilation, supporting myocardial function, and minimizing oxygen toxicity. Conventional management, right, we all know, includes oxygen, mechanical ventilation, and the use of vasodilators such as inhaled nitric oxide, which remains the standard of care for selective pulmonary vasodilation. Now, the point they're making is that in many resource limited settings, INO is not available due to cost and the need for specialized equipment. And they say that this creates a gap in access that has prompted interest in alternative therapies, that can achieve pulmonary vasodilation safely and effectively. So we get to nitroglycerin, a nitric oxide donor, which has emerged as a potential alternative. When administered via inhalation, it acts directly on the pulmonary vasculature, causing selective vasodilation while minimizing systemic hypotension. Now, there's previous studies in pediatric patients which show that if they have pulmonary hypertension secondary to congenital heart disease, and in adult undergoing cardiac surgery, that it is both safe and efficacious when given in this form of a nebulized treatment. They say that it has a rapid onset of action, it's easy to administer, and doesn't cost very much. I mean, nitroglycerin has been around for so long, adults have been taking it for so long that it's cheap. So
Mhm.
this study aims to investigate whether they could do this in their population of full-term neonates. So we'll get into the methods, if you will, if you wish. It's a randomized controlled clinical trial conducted in the NICU of Alexandria in Egypt between January and December 2024. They enrolled 80 full-term infants that were diagnosed with PPHN within the first 3 days of life, and the eligibility criteria for these infants were that they had to be born at or beyond 37 weeks, and they had to require a high degree of oxygen FiO2 of 50% or greater, despite long recruitment efforts, or who showed on echo signs of PPHN, such as tricuspid regurgitation greater than 50 millimeters of mercury and an abnormal D-shaped left ventricle. So, sort of flattening of the interventricular septum. Infants diagnosed after 72 hours who had major congenital anomalies or had major congenital anomalies were excluded. So they were randomized to two groups. The randomization is a big deal, obviously, here, because the nebulized nitroglycerin group received PPHN management plus the nitroglycerin, and the control group received standard care. The Nebulized nitroglycerin, if you are interested, is given at a dose of 2.5 microgram per kilo per minute for 10 minutes, repeated every 4 hours. Um, what is the conventional treatment that they received? So the issue is that they had sildenafil, basically. So they could not withhold sildenafil. If a kid has
Uh-huh.
PPHN, you cannot say, hey, you're randomized to the no
To nothing.
nitro. So they all received enteral sildenafil. And then obviously everything else, oxygen, mechanical ventilation, vasopressors, whatever else, everybody received. Only the nitroglycerin was different between one group and the other. The primary outcome was the change in estimated systolic pulmonary artery pressure, or SPAP, assessed through echocardiography. Secondary outcomes included other parameters on echo, oxygen indices like the OI, the duration of mechanical ventilation, the NICU length of stay, the need for inotropic support, and overall mortality. So 85 infants were randomized, 80 completed the study at baseline, no real significance between the groups in heart rate, blood pressure. But what they've noticed is that by the third day of treatment, infants receiving nebulized nitroglycerin showed significantly higher systolic and mean arterial pressures, suggesting improved cardiovascular stability. Notably, no episodes of hypotension related to nitroglycerin were reported. The nitroglycerin group also demonstrated a higher blood pH, a lower PCO2, indicating better gas exchange. And by the second and third day, oxygenation parameters such as saturation, FiO2, oxygenation index, and oxygen saturation index improved markedly in the nitroglycerin group, reflecting better pulmonary performance. In contrast, these same indices deteriorated quite rapidly in the control group despite standard therapy. In terms of ventilation, the modes of ventilation also shifted favorably among the babies who received nitroglycerin. By the third day, a larger proportion of the babies receiving nitroglycerin were supported by nasal CPAP, while more infants in the control group were still on a high frequency, and mean airway pressure values decreased more rapidly in the nitroglycerin group, consistent with improved lung compliance with nitroglycerin group. So I want to show you a little bit, and if you're following us on YouTube, you'll be able to see this as well. But it's quite impressive if you. I'm scrolling on the wrong screen, but you can see in the graphics of the paper that they have curves, and that is on figure 2, where basically the blue is the control and the red is the
Uh-huh.
nitroglycerin. And they measure on the y-axis several values. You can see in the first one here, I'm showing you in A, the oxygenation index. In B, you can see the oxygenation saturation index. And you clearly see the effect over the course of 3 days of nitroglycerin.
You really had to control yourself to ride it out for the first day. No
Yeah,
change the first day.
yeah, I would say that the first 2 days, there's no change,
Yeah.
even if the values tend to be lower.
Uh-huh.
But by day 3, wow,
Impressive.
the impressive difference.
Yeah.
And then same things with the pH. You can see a marked improvement, even though
Mhm.
then I would say for these other values, for the pH, for the PCO2, and for the SPAP, like the error bars start hovering over each other. So maybe less so, but definitely for these oxygenation values.
Very cool.
So um, yeah, in terms of echo, while the initial pulmonary arterial pressure was slightly higher in the nitroglycerin group, a significant reduction was observed by the third day, as we mentioned, and the ratio of SPAP to systemic systolic pressure also shifted. In terms of biventricular function, it showed that it was improved using measures of TAPSE, or ejection fraction, and fractional shortening. All are standard measures of functional echocardiogram that were better in the nitroglycerin group. Measures of cardiac output, including right and left ventricular outputs and stroke distances, also improved with nitroglycerin. So I think that you can continue to look. They also had a survival curve, which was quite impressive. Again, showing you in blue this time. I don't know why they didn't keep things consistent, where in one case the blue is
That is
the one.
very confusing.
That's okay, but showing the survival curve. Um, so the authors basically are demonstrating that you could potentially use nebulized nitroglycerin as a promising adjunctive therapy, at least for persistent pulmonary hypertension. Remember, they were using sildenafil on top of everything else. and it shows that it produced significant improvements in pulmonary hemodynamics, oxygenation, and cardiac function without really causing systemic side effects. Um, and obviously, they mentioned that we need further studies, but in resource limited settings, when a baby is not doing well, what's stopping you from finding another solution that has now been tested in several babies and could potentially help? So I think this is really neat.
Now we need a head to head.
Yeah, absolutely.
Okay. I was looking at I keep hoping azithromycin is gonna work. You know how much I like
Yeah.
azithromycin. This
I
was
saw that paper and I said, I don't want to have my heart broken again.
again, again. So this was, it's a review. It's a meta-analysis. It's in neonatology. Azithromycin for prevention of bronchopulmonary dysplasia and other neonatal adverse outcomes in preterm infants is an updated review and meta-analysis. This is coming out of well, a bunch of colleagues here. They're coming from Brazil, India, Massachusetts. I think. Did I get
Yeah,
everybody?
Massachusetts, that's correct.
Yeah, oh, the Mayo Clinic and the,
India.
all over. Anyways, they were really hoping that maybe if we pooled all the data together, azithromycin will shine. And it makes sense for people who are listening and you're like, why is azithromycin? Well, we know that maternal chorioamnionitis has been linked to the risk of BPD. We know that uroplasma colonization has been linked to BPD. And we know that ureaplasma has been linked to preterm birth. But every time we try to use azithromycin to target ureaplasma, we don't always we've not had a lot of success with azithromycin, unfortunately. So they looked at a number of studies. They wanted to include randomized controlled trials. They wanted them to compare azithromycin with placebo to prevent BPD in preterm infants, at least have one clinical outcome of interest. And they excluded studies with no control group, overlapping populations, a non-randomized control design, studies using antibiotics other than azithromycin, and studies using a different control, a different medication other than placebo. They wanted to look at the composite of BPD or death. They wanted to look at BPD. They wanted to look at death. They wanted to look at NEC, grade 2 or higher, IVH, grade 3 or 4, ROP, duration of mechanical ventilation, and postnatal corticosteroid requirement. And all the studies, BPD was defined as oxygen requirement at 36 weeks of gestational age or more. So ultimately, they included 6 randomized control trials. It included a total of 1,360 preterm infants. They had a mean gestational age at birth of 26.8 weeks included in the analysis. 4 of the trials used 10 mg per kg of azithromycin, and 2 used a higher dose of 20 mg per kg. Among and some of the studies looked for some of the studies gave it to everybody, and some of the studies looked for ureaplasma. So among the trials that reported their ureaplasma rates in their cohorts, 27% were ureaplasma positive. Okay, so for the outcomes, they basically took all these kind of pooled analyses. They looked at the composite of BPD or death. They looked at BPD. They looked at death individually. They were all comparable between the groups. The other oxidative injuries like NEC, IVH, ROP, similar between the control and the azithromycin groups. They looked at duration of mechanical ventilation and postnatal steroid requirement, also not significant, comparable between the two groups. Then they said, can we look at the babies who just were positive for ureaplasma? So they looked at this subgroup analysis, but still did not find any difference in the risk of composite of BPD or death in the ureaplasma group. So basically, their conclusion, which has been the ongoing conclusion, is that azithromycin did not significantly change the risk of these outcomes: the composite of BPD or death, BPD, death, grade 2 or higher NEC, grade 3 or 4 IVH, ROP, duration of mechanical ventilation, and postnatal corticosteroid requirement compared to placebo.
What about nebulized? I'm kidding.
Yeah, right. Actually, I was going to ask you, They didn't do a sublingual
I don't know.
nitroglycerin
I'm starting to wonder whether
for these tiny
ureaplasma
babies.
truly causes pneumonia and has a role to play in DPD, because then why wouldn't is it the
Then
right to
why
work?
wouldn't it work? Yeah. It feels like it should work.
I know. What a
But
frustrating
womp
endeavor.
womp.
But it's so funny to see all these papers come out because it shows that as a field, like, we want this to work.
We want it to work. We
It's
wanna
like
be able to offer babies something that, by the way, is accessible and inexpensive.
I
Yeah.
remember as a fellow, I was advocating for that as a fellow. I was like, "Listen, we had all these talks about the prevalence of ureaplasma
Yeah,
in
why are we
delivering
using
mothers. Just give it. What do we care? Don't test for it." And Dr. Benklari, rightfully so, said, "No, not
Nope.
without the evidence." But yeah.
Fine.
All right, it is my turn next. Yeah, I'm gonna take. I don't know if I have time for two more, but I want to talk about this one because
Hmm.
it came out in the Journal of Perinatology, and it's called "Identifying Optimal Positive and Expiratory Pressure with Electrical Impedance Tomography Guidance in Severe BPD."
I knew you were gonna pick this one.
Yes, first of all, I've been in talks with a lot of people about this because I'm
You're
very
very excited about it.
yeah,
Mm.
very excited about EIT. The first author of the paper is Jessica Shu, who is coming out of Boston. I've been in touch with Jessica. We're hoping to have her on the podcast next year to talk a little bit about EIT because I think this is going to be quite helpful in the NICU. This paper looks at basically how PEEP, right, which is a crucial component of mechanical ventilation. Um, and our goal really is to maintain alveolar recruitment, but to prevent at the same time overdistension, but also not cause atelectasis.
That much
So
I knew.
yeah, and so that's the balance we're always trying to strike with babies who have
Yep.
chronic lung disease or bronchopulmonary dysplasia. Now, the problem is that these infants are quite tricky. They exhibit areas of both collapse and overinflation, and which complicates our ventilation strategy. Now, the problem is that what we're doing is that we're either increasing PEEP can help the collapse regions, but then will overdistend some, and if you decrease it, then you might cause atelectasis. And so there's a new technology called electrical impedance tomography, also known as EIT, which is really promising, and I believe has just gone through FDA approval. And it is a non-invasive, operator-dependent, radiation-free, and provides real-time functional lung imaging at the bedside. If you've never seen it before, it's kind of like these electrodes. I may show my age here, but you remember these pulsar sort of heart rate monitor that they used to uh, purchase for runners? Like you
Mhm.
just like put this little strip. It can
I didn't think we were old enough to say that.
pulsar.
No.
Okay,
Just
good.
say I'm gonna, like, I'm gonna date myself here.
Yeah, I mean, I feel like pulsar is gone
Alright,
now.
fine, Pulsar, okay, fine.
Um,
It's the Radio Shack of running equipment.
that's exactly right.
That's right.
um, but basically, right. So it's like this little strip that you put on the baby's chest,
It
and
looks like a Holter monitor.
it looks like a halter. Yeah, but I mean, to be honest with you, it's kind of smaller than most halters.
That's true.
And it basically measures impedance changes as small electrical currents pass through across the thorax. And so EIT can actually visualize air distribution within the lungs. And the throughput that you get is basically like a little image of where the aeration is happening. And so you can see in real time how much aeration you're getting in each lung and which side is getting more inflated, maybe anterior if you're getting atelectasis, if you're getting over distension. So it's a really, really neat tool. I've spoken to some of the companies that are making it. At the time that I was speaking to them, they had not yet authorized to distribute in the US, but it is coming, and I think that there's some very interesting news. So the authors of the paper suggested that EIT guided PEEP titration could identify optimal PEEP that minimizes both overdistension and atelectasis. And this is a case series. So I'm not really going to bother you with the methods. Basically, they're reporting outcomes on a variety of cases, and you can read them. There's about like four, I believe, four cases, and then they took an additional four cases where the babies did not really have BPD, sort of almost as control. But I kind of want to show you this because you're gonna, yeah, this is the kind of stuff I feel like if we bring this into the unit, you're gonna want on all our BPD patients. But look at that, like it gives you these little sort of quadrant of like
It's so cool. Yeah,
it's very neat.
it's very neat.
So
You could imagine that using this data, you could just say, like, let's turn the baby this way and recruit more alveoli,
That's exactly what
it's
they did.
really
I'm gonna
cool.
I'm gonna tell you the story of two of their patients, and then I'm gonna
Yeah.
invite you to read the paper because it's very interesting. The first one, which they call BPD subject 1, is a male infant, small for gestational age at the 9th percentile, born extremely preterm, required a tracheostomy for chronic ventilator dependence. He's receiving SIMV with pressure control ventilation, and basically the team had to escalate his PEEP to 14 centimeters of water while receiving about 45 to 50% FiO2, with a mean airway pressure of about 22 centimeters of water. And basically, what they did is that they used EIT and they were able to do PEEP titration, and they identified that actually the PEEP that led to no atelectasis with optimal inflation was a PEEP of 10. And the baby had then remained clinically stable for at least like another 10 months on this EIT determined optimal PEEP, with now FiO2s much lower, 30 to 40%, and did quite well thereafter. Another interesting baby was this BPD subject number 2, I believe, BPD subject number 2, which is here. And it's a 5-month-old. That's a former 25-week infant that is intrauterine growth restriction, failed non-invasive support after low-dose dexamethasone, remained chronically intubated on SIMV via a tracheostomy. And 1 week prior to the EIT-guided PEEP titration, he had like kind of a hypoxic event where they basically had to escalate his PEEP to 11. He was on 40 to 50% O's, MAPS of 19, and eventually to a PEEP of 14, requiring 80 to 100%, MAPS of 25, so really a worsening of his respiratory condition. They also added nitric oxide. They sedated the baby. Neuromuscular blockade was initiated. And given the challenges in supporting oxygenation, they asked to do an evaluation with EIT. Taking the long over distension on his chest X-ray into consideration, a long recruitment maneuver was not performed, right, prior to the EIT guided PEEP titration, and the lowest PEEP evaluated was 8, which resolved the over distension and did not induce atelectasis and improved lung compliance. Furthermore, there was an improvement, they say, in regional ventilation with a gain of tidal volume. And after decreasing his respiratory support PEEP of 8 and MAP of 14, his FiO2 requirement decreased from 86% to 25% over the course of 3 days, notably lower requirement than his baseline prior to the decompensation. They lifted his neuromuscular blockade after about a week. And empirically increased the PEEP to 9 and a MAP of 15 due to expected dynamic collapse. And his FiO2 increased to 50% with spontaneous breathing. He remained on a PEEP of 9 for about 1.5 months after EIT-guided PEEP titration. And so what's super interesting to me is that as you're reading the paper, it basically shows that like the clinicians have the right idea that like, hey, we need to support this baby better. But our assessment clinically at the bedside of like how much PEEP is enough to actually do the trick is often overestimated. I feel like in a lot of these cases, what the team found was that these babies were on higher PEEPs than they needed to be. But it's very hard to find what is that right number if you don't have the indication on a dynamic sort of modality that you are not causing atelectasis. So
Yeah, and I think it always feels scary to go down, right, on an unstable baby, even when
yeah,
you know that maybe it will help them.
because if you see those sats drop by just for a
You
second,
go
you're gonna be like,
turn
"Oh,
right
she
back up.
doesn't like it. The kid doesn't like it. Go back, go back," um,
Yeah.
because we're so reactive. Um, and even sometimes, like if you're the neonatologist, on how many times have you done this where you lower the PEEP by 1, right? And
Mhm.
then some random event happens overnight, which most likely has nothing to do with what you did.
That's right.
But just because you did it, it goes back up. The
Goes
PEEP
right
goes
back
back
up.
up by 1 because the baby's toe sort of turned the wrong way. And it's like, that doesn't have to do anything with this PEEP, but that's the way we work. So that was funny. So that was it's a very interesting paper. I would say that next year I'm going to make a point to try to talk to more people about EIT, because I want some in my unit, to be honest with you. And
Uh-huh.
I feel like this could be very, very helpful. And I think that Jessica out of Boston is doing a very good job trying to slowly bring this to the NICU. So I'm looking forward to speaking to her next year as well on the podcast.
So if you're a company who does EIT,
I
let us
spoke to
know.
them already.
I
It
know
was
you
it was a frustrating thing because I wanted to get them in touch with our hospital to purchase,
Mhm.
but it's only been used thus
Mhm.
far for research
Research, yeah,
purposes.
it's not really.
But I think that is has either already changed, and I think that by next year people will be able to purchase them. So it's a very cool tool. It's
Mhm.
non-invasive, no needles, no nothing, and
Well, and
because
especially we've just reviewed that paper that, like, look, chest X-rays are
are not
are
reliable.
not
Yeah.
that reliable looking at chest expansion, and you're like, "Well, then."
And the dynamic studies that we do I mean, in our case, we were doing them when we were at Drew Maggio Children, and
Uh-huh.
we're still doing them. The idea of doing um, pulmonary pulmonology sort of directed bronchoscopy and try to do dynamic PEEP studies where we basically lower the PEEP.
Right.
It's kind of the same idea, trying to figure out
Mhm.
like at what point am I losing my patency of the airway. Obviously, it's not as precise as you would do under direct visualization through a bronchoscopy, but it's kind of an invasive procedure. So
Mhm.
if you're able to do it with just like a little bit of a
Sure.
strap over the chest and get some information that correlates with that. I'm sorry to all the pulmonologists I'm upsetting right now on the air, but that's
Well
quite neat.
what they can't do is a longitudinal evaluate, right? And these babies change every day sometimes, it feels
Yeah,
like.
it's a
So,
spot
yeah.
check. You're
Yeah,
right.
for
Yeah,
sure.
you can't bronch them every day.
No.
You could do this every day.
Yeah, very cool. I have time for one more?
Please. Yeah.
It's a short one, but I think it's a kind of a cool study. So this is in the Journal of Perinatology. It's entitled Risk Factors Associated with the Development of Necrotizing Enterocolitis in Preterm Infants on an Exclusive Human Milk Diet, a Single Center Case Control Study. The lead author, Haider Al-Lumarab. Okay, and this is coming to us from Oklahoma Children's? Yes, and the University of Oklahoma. So, what I thought was unique about this paper is, the entire group of babies that they looked at was on an exclusively human milk diet. So, mom's own milk, donor milk, and a human milk derived fortifier. So taking out that whole, um, factor about what were the babies fed. So I thought that was really cool. This was a retrospective matched case control study. They're a level 4 NICU. And so infants diagnosed with NEC were then matched to control infants based on specific criteria. And the inclusion criteria were infants less than 32 weeks gestation at birth and less than 1,500 grams at birth who received an exclusively human milk diet until 32 weeks post-menstrual age between January 2016 and March 2023. Um, and then controls were defined as infants who did not develop NEC while receiving the same diet, also exclusive human milk. And they were targeting a ratio of 1 to 4 cases to controls. And controls were matched with cases based on birth weight plus or minus 200 grams, gestational age at birth plus or minus 2 weeks, and birth date plus or minus 6 months, um, to help evaluate kind of any in-unit factors. And each control was used only once. Infants with known major congenital anomalies were excluded due to potential confounding effects. Okay. We don't have a lot of time, so I'm just going to hop into
No,
the
take your time. Take your
take
time.
your time. Take your time.
You may not have time.
Well, maybe. We're going longer than usual tonight.
We're going longer than usual.
Okay. So they found
But it's a very interesting paper.
it's a very interesting. So they found 53 cases and 1,019 controls. Then, using their more strict inclusion and exclusion criteria, they had 27 cases and 98 controls eligible for the study. Um, and just to confirm their control ratio, for 10 of the cases, they had 1 to 3 cases to controls. And for 17 cases, they had 1 to 4. So cases to controls. So it's a small study, but interesting nonetheless. Okay. Cases had a mean
Could it be that it's a
gestational age
small
of,
study because a completely human milk diet provides you less patients with neck?
sure, but absolutely. Absolutely. Though in our unit, babies less than 32 weeks are on a,
Strictly human milk diet.
yeah. Anyways, moving right along. Cases, so those babies with neck, had a mean gestational age of 27.2 weeks, a mean birth weight of 928 grams, and the controls were similar, a mean gestational age of 27.4 weeks and a mean birth weight of 960 grams. They looked at a number of maternal and infant characteristics, and there were no significant differences between the two groups. For the babies who developed neck was diagnosed at a mean age of 22 days, with 26% of cases classified as stage 3. Surgical intervention was required in 15% of cases, with mortality due to neck at 22%. Among survivors, complications included short bowel syndrome in 11%, TPN dependence in 15%, cholestasis in 22%, and recurrence, unfortunately, in 7%, while 48% had no major intestinal complications at discharge. But 52% did. There's so many. Blood cultures were positive in 30% of cases, and the average duration of antibiotic therapy was 8 days, with vancomycin and amikacin being the most commonly used antibiotics. So then they looked at the prenatal factors. So all of these babies got exclusive human milk. What was different about them? And 2 factors were significant in univariate analysis. The mean maternal neutrophil to lymphocyte ratio before delivery was considerably higher in the neck group, averaging 13.6 compared to 6.3 in controls. And this was statistically significant. I know that you're always calculating those maternal neutrophil to lymphocyte ratios. So
Mhm.
definitely something that I had not previously thought to look at for this group of babies. And the second factor was maternal urinary tract infection within 1 week before delivery, much more common in the neck group, in the neck, in the mothers of the neck group, affecting 19% of cases compared to only 2% of controls. And this was statistically significant. Other prenatal factors that they looked at showed no significant differences between the neck cases and controls. They looked at early postnatal factors, in particular fluid and nutritional parameters between cases and controls across the first week of life. And really, the thing that showed a difference was the need for vasopressor or inotrope support within the first week of life. This was significantly higher in cases, found in 26% compared to controls, 8%. Additionally, the presence of a PDA requiring treatment up to the time of neck diagnosis was more common in cases compared to controls. Other analysis of nutritional support looking at the period leading up to the neck diagnosis showed no significant differences across all nutritional parameters looked at, with the exception of decreased feeding advancement rate in the cases. So, um, the cases were not being advanced actually as fast as the controls. 9 mLs per kilo per day compared to 12 mLs per kilo per day in the controls. And then they wanted to look at these, they wanted to create these models. So they did this model 1, looking at the neutrophil to lymphocyte ratio. Am I saying that right? N to L is, yes, neutrophil to lymphocyte ratio and UTI in model 1. And then they tried to include race, because such a significant association of neck in these Black babies. So model 2 then incorporated all of those plus the addition of postnatal vasopressor use. Okay. So, maternal UTI prior to delivery and infant vasopressor use in the first week of life were associated with a higher likelihood of neck, as was a higher maternal N to L ratio. And in model 2, the maternal race showed a trend towards significance. It was a P of 0.076, with infants of Black or African mothers showing a higher risk of neck compared to infants of other races. And then they show kind of these 4 graphs, these combined logistic regression likelihood of neck graphs. And the highest neck risk was in infants of Black mothers receiving vasopressors with maternal UTI and with a high N to L ratio. So nothing for us to do about that except to recognize potentially those factors as higher risk for the development of neck and
Yeah.
maybe look at them more closely.
Yeah, but I mean, I'm curious what you make of this because, right? I mean, to be honest with you, um, there's two of these factors that not that I don't care about, but I feel like, okay, I'm not really surprised, right? I feel like vasopressors, you're like, okay, like vasopressors, I can like if a baby is that sick in the beginning of life, then sure, it's not ideal. But what's interesting to me is obviously like maternal race. I feel like is also something that's going to differ based on where you practice. I believe that this is something that is very location dependent as well, depending on the makeup of your population and so on and so forth. But it's these maternal factors that I never ask about.
Sometimes they've been worked up for it for the preterm delivery or, preterm labor.
Yeah, did they specify like? But I'm assuming also like we don't really have a good understanding of. Um, I mean, they mentioned within 1 week prior to delivery.
Mhm,
Um, to be honest with you, we don't know that.
mhm.
We don't know that. If their urine dip is clean at the time of admission, I think that's
Sure.
not right.
Yeah, 100%.
Only good OB units will probably ask, like, "Have you had an infection in the past 7 to 14 days?" or something like that. Yeah, and
For
we don't
sure.
ask. We
No.
don't ask. And then this, maternal, neutrophil to lymphocyte ratio is not something I'm used to looking at. It's interesting because these are I mean, yeah, these 2 are quite staggering, and again, I'm gonna do a better job at maternal UTI. I feel like unless I am prompted, I don't usually ask about it.
Yeah, and I think by the time neck rolls around, we've already forgotten about most of
If you remember how
the
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 baby was delivered,
prenatal
it's already pretty
the
amazing.
prenatal history, admittedly, right? I mean, we may go over it, we may talk about it, maybe on our little sign out sheets, but, here in this group, the neck was diagnosed in a mean age of 22 days, standard deviation of 9. So, we're already
Yeah,
3 weeks into this thing,
that's what
and
I was saying, like, how
yeah.
many times when the kid's, like, 3 weeks old, you'd be like, "Did you have a UTI around the time of birth?" It's like, yeah, if I remember why the baby was delivered via C-section, it's already pretty amazing. Like, all this information sort of filters. It's somewhere, but I'm sorry to say, most medical records today have not made access to the
Yeah, and I
information
mean, I think
better.
we use that information to make decisions about the early
Early onset sepsis.
antibiotics.
Yeah,
Sure, yeah, of
exactly.
course. But it's just so interesting. It's just such a reminder about I mean, neck is so interesting because it's these things that are happening prenatally, right? This inflammation prenatally, or man, yeah, we there was I don't know, bowel ischemia in the first week, we needed pressors, and now 3 weeks later, we're having this problem.
Yeah.
It's really, really interesting. And again, I mean, this is a study in the US. Obviously, it underlines ongoing, risk factors by racial demographics, and I mean, that is just until we change our societal, setup for healthcare is an ongoing problem.
Yeah. Yeah, and that's something that, like I said, I think is gonna be very, very location dependent. I think that, everybody is gonna have to adapt that specifically to where they work. But, yeah, those maternal CBCs and maternal UTI, I mean, again, I was thinking about that today about, like, billing and coding and the problem lists and everything, and it's really not tailored for neonates. Like,
Mm,
maternal history should almost be, like, in a sub-problem list for these
yeah.
babies. Whatever these mothers have, it connects to your patient one way or another. Even
Yeah,
if
right. It's because in adults, if have a heart attack, you have the hypercholesterolemia, you have the hypertriglyceridemia, you have hypertension. But for babies, their risk factor is the maternal
and they should be
factors, the
connected.
maternal history.
I'm
Yeah.
gonna tell the story today that it's not HIPAA, but, like, one of the mothers of the babies that we were rounding on was wearing a mask. And
Hmm.
so, obviously, I'm a and this is a baby on respiratory support, so I
Hmm.
wanna find out, like, is this mother having a viral illness? Like, it would be very pertinent for me to know. And and, um, and turns out no, that turns out that the bleach is just irritating her. So it was absolutely nothing. But can you imagine if like a mother went to get checked by their primary care physician and whatever problem is diagnosed shows up on your problem list?
Mm.
Can you imagine how valuable that piece of information from an
Well, we get that all
epigenetic
the time. It
standpoint?
trickles down. The mom's been readmitted because she actually has a raging infection, or the mom's been readmitted because, yeah, she has blood clots, or, for sure. Yeah,
Yeah.
very
But I
interesting.
think we're not, yeah. I wanna, yeah. My takeaway is I think we should be more explicit. We should tell these parents, "We wanna know everything about you." Like, if
Mm.
something happens while your baby is here, I wanna know, and because it definitely impacts how we can care for your baby. And it is kind of crazy that, you know, those parents, the ones that are very, introverted, they don't talk, they just come and they're very quiet, like, that's not right. Like, we should be able to still serve them as well as the one.
Sure.
Yeah.
Yeah, a family who may not know
Disclose.
to disclose, want to
Yeah.
disclose. Yeah,
Yeah.
as there are some families that will disclose everything.
Everything.
That's right. Yeah. Okay.
Alright.
Well, I
Alright.
have another one, but it's gonna have to stay for next time.
Yeah, same. But we had a good discussion. This was a fun journal club.
For sure. Alright, buddy.
Alright, everybody.
Get some rest.
Don't forget to register for Delphi, and we'll
Mhm.
see you guys next week with some NRP updates. Very cool.
Very cool.